Dear friends and colleagues, thank you again for the possibility to be part of the event. Now I want to present an interesting vision about a patient with keratinocyte cancer. The title is Double Hatchet Lab for SCC of the scalp occurring during treatment with VALSARTAN hydrochlorothiazide and LERCANIDIPINE, links to photo-NITROSO carcinogenesis. This research did not receive any financial support and there is no conflicting interest. As we all know, the polycontamination within the multi-medication in polymorbid patients could be seen as one of the most serious obstacles for the current concept of the modern skin cancer pathogenesis, probably exactly in relation to the so-called metabolic reprogramming of the future cancer cell. The announced official hypothetical contamination of more than 250 drugs worldwide by the FDA in April 2023 and the establishment of permissive concentrations for 5 classes of carcinogenic activity of the nitrosamines and NDSRIs effectively make any preventive step more than impossible or meaningless at the current moment. There are two very interesting facts that could be not ignored in any way. Certain nitrosamines, such as NDMA, for example, could have a direct activating action towards certain oncogenes, such as the RAS oncogenes, while at the same time, once metabolized in the liver, their active metabolites could also have mutagenic or carcinogenic effects, such as methyldiazonium, for example. That is, monocontamination with a single nitrosamine could have or bear the risk of polycarcinogenic effects in humans, given its metabolized and unmetabolized form. Present carcinogenic and or mutagenic are acting probably simultaneously. It is unknown till the current moment. Oh, this is not our statement. This is a statement published officially in the YAMA network, open by Michael Wild, and especially this is the worrying one. The NDMA contamination in drugs may act as probable carcinogen, but also as a mutagen at different levels in the human body. It is for this reason that even the monomedication and contamination with nitrosamines could also be seen as highly problematic for the metabolic reprogramming of the future tumor or cancer cell, which seems to be important for unraveling concepts such as nitrosogenesis and oncopharmacogenesis of skin cancer, and especially the drug-related nitrosogenesis and oncopharmacogenesis. In this relation exactly, we would like to comment the keratinocyte cancer development and progression within the intake of several potentially nitrosamine contaminated drugs like VALSARTAN hydrochlorothiazide and probably LERCANIDIPINE. All two drugs have been listed already and currently are presented in the FDA list from 2019-2023 for potentially nitrosamine contaminated medical products. Sartans like valsartan could possess carcinogenic activity or potency between 1 or 2, and thiazide diuretics like hydrochlorothiazide could possess a similar carcinogenic potency but weaker of 4. That's why we think that the intake of these two medications could be seen as equivalent to the intake of carcinogenic cocktail, which could act as possible trigger for the development and progression of squamous cell carcinoma of the scalp, and especially because the most nitrosamines seems to be very well-known phototoxic agents or substances. We report an 82-year-old patient attending the outpatient clinic for dermatologic surgery for a new onset tumor-like lesion approximately 1 to 1.5 years duration localized in the scalp area. An year ago, he underwent outpatient cryotherapy of the scalp due to suspected actinic keratosis without histopathological verification of the latter. The comorbidities were known to be varicose veins of the lower limbs and arterial hypertension with a history of 10 years. And systemic medication of the patient included VALSARTAN hydrochlorothiazide once daily from January 2020 till 2023, LERCANIDIPINE for the last 3 years, once daily. According to the domestic history, the patient was taking another medications before the already stated one for his disease or illness, the arterial hypertension. However, this could be not clarified at the time of hospitalization or within the dermatological examination. We have seen ultranuclear formation of irregular shape and size of 7.5 to 5 centimeter, covered with yellowish exudate in places, peripherally forming dense brownish crusts, such as well confluent dorsomedially localized satellite erosive lesion, covered with a tightly adherent crust. Clinically and dermoscopically, the lesion was suspicious for keratinocytic or epithelial tumor. Paraclinical and operative diagnostic procedures were without evidence of metastasis, and surgical removal under local anesthesia was planned with moderate cardiogenic risk and the need for close monitoring during the intervention. After the disinfection of the surgical field and placement of a local anesthesia with lidocaine, oval excision of the primary tumor was performed with a surgical margin of no more than 0.5 cm in all directions, followed by a double hatchet flap with rotation and adaptation of the wound edges in the periphery. Subsequent histopathological verification was indicative for G2 squamous cell carcinoma of the skin with infiltration of one resection line. Staging was determined to be T2M0M0R1. Clinical observation of the patient and re-excision, if needed, was additionally recommended after on the tumor board. Here I'm showing the lesion before performing the double hatchet flap. Of course, we have to measure exactly the parameter, how it has to be cutted. First of all, you see the ovular excision, and then we have stopped the bleeding. After that, we have started additionally to perform the flap from the one side of the flap, then the second part of the flap, and here you can see the undermining under local anesthesia of this old patient, and it was some tension and pressure. You can see the scalp area, all bleeding has been successfully stopped. After that, we have tried to adapt it with it is important to see which edges have to correspond with which one and where the stitches and which type of stitches has to be performed. Then we have taken the decision to start, of course, with the adaptation, and here you see that within probably 30-40 minutes we have adapted each of the wound edges to the opposite side without any or with a very small pressure. Accordingly, here as you can see, the force awakens. It's a famous film. However, it's always first a little bit difficult. However, you see a laughing patient and our operation sister, and the patient is in a very, very good condition. Then you can see I think this is on day 21, and after that on day 28, we see that there is only single stitches for removal, and we were, of course, satisfied with the result. Here you see after 4 or 5 weeks, the tumor of the scalp has been removed surgically and no complications arrived in the postoperative period. Systemic medication intake was not stopped. So, why we present this case and what do the surgery has actually to do with the drugs? It is a link between drug intake, the need of surgery, and the tumor development. That's why we would like to explain our thesis or hypothesis at least. We know that the metabolic reprogramming is a hallmark of cancer development and progression, and the link between oncogenes activation like RAS and tumor suppressive genes inactivations, the regulator of the genome, are very, very good and well known for fast all types of tumors. However, numerous carcinogenic environmental factors seems to be responsible for the early cancer initiation, and their impact on metabolic reprogramming just starts to be elucidated or deciphered. The most important factor is the UVB radiation, UVA also, and the tobacco-specific nitrosamines, the so-called TSNAs, which also belong to them. The most reasonable questions to clinicians should probably look some type of provocation, but like this. Should the concept of metabolic reprogramming on the photo-nitroso carcinogenesis of the tumor cell of the skin, for instance, differ only due to the fact that carcinogens enter the body via controlled permanent continuous drug intake rather than via cigarette smoke or the sporadic intake? And this is a very, very good question. Because the concept of the global cancer incidence is more than a frightening one and predicts a dramatic increase in the number of newly diagnosed cases by 2040 of approximately 50% and even more. Non-melanocytic skin cancer, but melanoma also, and their incidence are also rising at a breakneck pace, with this increase corresponding or increasing exponentially with the number of nitrosamine-contaminated concomitant drugs taken, according not to us, but to the official FDA lists. Concurrent intake of drugs of heterogeneous classes or nature, declared as hypothetically contaminated with carcinogens, according to the FDA list, again, could hardly be limited even within the limits recommended by regulators. It is the contamination of polymedication taken by patients within polymorbidity that appears to be the most likely probable cause or cofactor of cancer in general. The thesis presented so far that polymorbidity is the cause of cancer is gradually, but more than surely, losing its supporters. Nitrosogenesis of skin cancer is a modern concept in the medical literature that links the intake of nitrosamine-contaminated drugs and the subsequent development of heterogeneous forms of skin cancer. The dilemmas remains until now between the balance of officially disclosed to or from regulators and the hidden not disclosed from big pharma to patients contamination data about the medical products. From this, it is noteworthy to mention that the concomitant intake, for example, of two drugs with potential carcinogenic potency of 2 and 4 for a relatively short period of time, 3 years, VALSARTAN HATCHET, could be associated with the simultaneous manifestation occurrence of one cutaneous keratinocyte cancer located on the scalp, for example, and actinic keratosis. Of course, we see that we have a 2 and 4 carcinogenic potency for this medication. VALSARTAN could be also linked here like all sartans. And of course, hydrochlorothiazide is also in the FDA list. And we have also to mention that nowadays many of the calcium channel blockers belong also to the list of the contaminated drugs regarding the FDA. One of the most fresh examples is amlodipine. Probably, I say probably, NITROSO LERCANIDIPINE. There are tests for it. Probably it will also be linked later or in the future in this contamination list. At the moment, it is still not there. Metabolic reprogramming, drugs, nitrosamine, skin cancer, flaps. This is more than a real craziness. And what several new important international papers shed light on possible links between oncopharmacogenesis, drug-related photonitrosogenesis, photocarcinogenesis, and skin cancer. What is the worrying one? Some nitrosamine seems to be photocarcinogens, photocarcinogenesis, well known since decades. Some nitrosamines have mutagenic carcinogenic action in humans, p53 and RAS, TSNA. Some medications contain nowadays photocarcinogens, nitroso photocarcinogens, as a substantial part from the human medication, nitrosomorpholin, for example, in monosidumine. So that metabolic reprogramming by tobacco-specific nitrosamines in cancer is a well-known scenario. We have already spoken about this, and according to the International Agency for Research in Cancer, tobacco smoke is Mayer class 1 carcinogenic environmental factor that contains different carcinogens, but little is known on the impact of tobacco smoke on tissue metabolism and its participation to cancer initiation. Tobacco-specific nitrosamines play a pivotal or central role in the tobacco smoke-mediated cancer initiation. And as the other important fact is that UVB radiation triggers metabolic reprogramming also. And from cultivation to cancer, formation of nitrosamines and other carcinogens in smokeless tobacco and their mutagenic implications is important to be mentioned because they are absorbed and metabolized to reactive compounds that form a DNA adducts, leading to mutations in some critical human target genes like RAS oncogenes in P53. We know that the genotoxicity and instability of nitrosomorpholin following not UVB and UVA radiation. Here we have not only UVB, we have UVA-mediated phototoxicity, wider spectrum of possibilities leading to skin cancer or potentiating the skin cancer pathogenesis. And this study investigated the nitrosomorpholin genotoxicity following UVA radiation without metabolic activation, and it was observed that photoactivated and more attached air could float in the air and fall on the body of the humans, leading to genotoxicity induced by the radiation and more. So that what postulates this study? Nitrosomorpholin is nitrosamine, nitrosomorpholin is genotoxic and photocarcinogen, without metabolic activation is mutagenic, could be seen as potential environmental genotoxic factor when found to human body, probably big carcinogen like NDMA, as we have already spoken. Prevalence of nitrosamines contaminants in drug samples. Has the crisis been overcome or is it starting just now? A very important journal, of course, German Archive Pharmacy of Weinheim. They have found that analyzed some drug samples, and the findings regarding the nitroso contamination included 4 active pharmaceutical ingredients like losartan and the contaminated valsartan, metformin, and ranitidine. And they have found that there is a possibility that the 5th new finding, which has been not reported yet, discovered contamination of moxidumine tablet sample with nitrosomorpholin. And this is a really important paper because they have found that the tablet contained 144% of the toxicological allowable intake for N more. This is a problem because this paper is indicative that we have the following situation. Polycontamination of a single drug with 2 nitrosamines is a reality and not a myth. Contamination of drugs with nitrosamines, which are already proven as photocarcinogens like nitrosomorpholin, is already a reality. These nitrosamines have their mutagenic but also carcinogenic action before and after metabolizations. So that the scenario of the so-called metabolic reprogramming seems to be very possible or couldn't be excluded at the moment. There is no single medical product on the drug market where we can be sure that it hasn't been affected due to nitroso contamination. Nitrosamine checks must happen and to stay the rule in order to secure the patient's safety. Clinical pathological correlations need to be from paramount importance, as we are showing this in our congresses and conferences. The polycontamination, monomedication and polymedication appears problematic with respect to the future development of heterogeneous types of cancers, including skin cancer, keratinocytic cancers. The monitoring of these possibly interrelated events could and is indicative of the key role of drug-related nitrosogenesis in skin cancer generation. We present our data in this regard. We have a similar combinations case series where we have published that the combination with HYDROCHLOROTHIAZIDE and calcium channel blockers with sartans could also trigger the keratinocytic cancer development and progression. The same like in this presented case. Additionally, we have another case series of patients where we have followed that sartans with calcium channel blockers could also be linked to the development of skin cancer. So, our current study or presentation seems to be indicative again that the possible contamination of these 2 medications with nitrosamines could bear the risk or play at least a cofactor role for the probable development of HCC and actinic keratosis. Nitrosogenesis, drug-related and oncopharmacogenesis of skin cancer seems to be a reality and not a myth. Short-term intake of 2 or 3 potentially contaminated drugs poses or could be associated with a relatively short-term risk of developing keratinocytic skin cancer, as in the case presented. The fact that a substantial number of international clinical follow-up studies, past and present, have also linked some of the most commonly distributed potentially nitrosamine-contaminated drugs to the subsequent development of different types of skin cancer is indicative of such connection. The careful analysis and follow-up of the intake of some new classes of potentially or actually really contaminated products, like xanthans and hydrochlorothiazide, probably also LERCANIDIPINE and analogs, are able to lift the veil concerning the drug-related photonitrosogenesis and carcinogenesis and drug-related oncopharmacogenesis in relation to skin cancer. Of course, we want to focus the attention to one very important paper published in a very well-established and positioned journal of the Journal Dermatological Society for Dermatology, JDDG, hydrochlorothiazide and increased risk of atypical fibroxanthoma and pleomorphic dermal sarcoma. Overall, they have studied cases and used with atypical fibroxanthoma and used additionally some controls with HCC and BCC, and they have the colleagues find out that hydrochlorothiazide was significantly higher in patients with atypical fibroxanthoma and pleomorphic dermal sarcoma with about 44.5% compared to patients with squamous cell carcinoma and basal cell carcinoma, 25.3%. That means that after the use or during the use of hydrochlorothiazide, we have 4 types of skin cancer developing. Additionally, the presence of diabetes mellitus was significantly higher in this group of patients, especially atypical fibroxanthoma and pleomorphic dermal sarcoma. As we know, diabetes medication, we will post these findings in another paper and in another lecture, is associated with the intake of metformin, sitagliptin, and other antidiabetics, which are also one of the most terrible contaminated drugs on the current market. Indirectly, this is a confirmatory statement that additionally the presence of diabetes mellitus was significantly higher in atypical fibroxanthoma and pleomorphic dermal sarcoma. That means that polymorbidity due polymedication could also trigger the phototoxicity and photonitroso carcinogenesis. Let us see another interesting story. Journal of very well-positioned journal speaking about antihypertensive medications and risk of melanoma and keratinocyte carcinoma, a systematic meta-analysis. It is one of the last. It is 2024. They are saying that squamous cell carcinoma with calcium channel blockers, we have about 8 to 10%, and thiazide, we have 36%. This is very, very worrying and confirmatory to our study. We are presenting such type of patients taking both medications. We have not to wonder that they have developed skin cancer. Our study is confirmatory of that, or this study is confirmatory of our study because our findings were published and a long time before this study has been officialized. Photosensitizing antihypertensive medication and the risk of cancer among postmenopausal women. It is again a very interesting study published in the German Dermatological Society of Germany, a specialized journal for dermatology, where they find a 30% risk to develop skin cancer and 17% of risk to develop after use of calcium channel blockers and thiazides, with higher non-melanoma skin cancer. And non-melanoma skin cancer linearly increased with the use of multiple antihypertensives, that means probable multiple contamination with nitrosamines and with longer duration to use. This is more than indicative of our research. This is a completely confirmation of our findings. future important directions to be clarified or just to be stated. For the dermatological science, however, some important dilemmas remain regarding nitrosamines and their pathogenetic relevance to skin cancer, such as does certain additional autoimmune nitrosamine or its metabolites have a triggering point to absorb photons and trigger phototoxicity and photocarcinogenicity? The answer is completely yes, well known. Does it or its metabolites have the potential for systemic bioavailability and the possibility to accumulate in skin and trigger cancer? The answers to these questions are somewhat and more than clear, but there are delays detrimental to the objective truth concerning the fate of billions of patients. Phototoxicity and the hepatotoxicity as biological indicators of nitrosamines have been studied in 1974. And colleagues have studied 22 nitrosamines, was studied from the standpoint of evaluating their phototoxic and hepatotoxic properties as a biological parameters for purposes of bioassay. With respect to differentiation between carcinogenic and non-carcinogenic nitrosamine, phototoxicity appears to be a non-specific effect related to the photodecomposition of the nitroso group. We have the answer of this question already in 1972, that phototoxicity is a non-specific effect of nitrosamines, independent if they are carcinogenic or not. That means this could be not captured by the FDA tests in AIMS tests in bacteria or CPCA tests in rodents. This is not genotoxicity. This is another type of carcinogenicity triggered by additional phototoxicity and carcinogenicity. This is very, very important study. That's why it's better to know the history of science and in medical investigations. As a whole, we can state that photonitrosogenesis of skin cancer remains no more a hidden truth and at the same time controllable process, especially the drug-related nitrosogenesis is an essential part of the oncopharmacogenesis or skin cancer's pathogenesis. Polycontaminated drug intake could be and is very often associated with the development and progression of keratinocytic cancers. Dermatologic surgery and complicated flap techniques still remain the best decision for skin cancer with complicated locations and multiple skin cancer lesions developing simultaneously. We have the honor to publish this paper in the Georgian Medical News. A very well indexed paper in PubMed and Medline, and we still are very happy about this realization. Thank you for your patience and for your attention. Many greetings from the Bulgarian Society of Dermatologic Surgery.